Good evening, one and all. Hi, this is Dr. Gayatri, Professor Department of ENT. Today, in this lecture, I shall be enlightening you all about one of the important intracranial complication of otitis media and a very commonly asked essay question: lateral sinus thrombophlebitis. What is lateral sinus thrombophlebitis? It is the inflammation of the wall of the sigmoid sinus and the transverse sinus, which are together known as the lateral sinus. Coming on to the pathogenesis, lateral sinus thrombophlebitis can occur as a result of both acute as well as chronic otitis media. The first step in the formation of a lateral sinus thrombosis is the perisinus abscess. Perisinus abscess is a collection of pus between the sinus plate of the mastoid and the outer dural lining of the sigmoid sinus. This abscess can occur either because of direct bony erosion of the sinus plate or because of thrombophlebitic spread. Once the perisinus abscess has collected, it starts irritating the outer layer of the sigmoid sinus. This is indicated by the pink color in this particular picture. Once the outer layer of the sigmoid sinus gets inflamed, the inflammation spreads through the wall of the sinus into the interior of the sinus. Once the intima or the inner layer of the sigmoid sinus gets inflamed, it starts attracting the platelets, the RBCs, WBCs, fibrin to the inflamed area, which together lead to the formation of mural thrombus or a thrombus within the lumen of the sigmoid sinus. This thrombus can either completely obliterate the lumen of the sigmoid sinus and propagate in various directions, or can break down because of the action of the beta hemolytic streptococci, causing release of septic emboli into the bloodstream. In this context, I would like to mention that the beta hemolytic streptococci are one of the most commonly implicated organisms in causation of lateral sinus thrombophlebitis. Once the septic emboli are released into the bloodstream, this leads to frank septicemia. The thrombus within the lateral sinus can extend in various directions, as I just mentioned some time back. If it extends downwards, it can grow into the internal jugular vein into the right side of the heart. If it grows anteriorly through the superior petrosal sinus, it can extend into the cavernous sinus. If it's going posteriorly towards the confluence of sinuses and then superiorly toward the superior sagittal sinus, it can lead to superior sagittal sinus thrombosis that in turn leads to blockade of the arachnoid villi along the walls of the sinus and subsequent raised CSF pressure or otitic hydrocephalus. What are the clinical features to suggest lateral sinus thrombophlebitis? The first and foremost classical symptom of lateral sinus thrombophlebitis is the hectic picket fence pattern of fever. Here, the temperature keeps fluctuating, it keeps rising and falling, but it never touches the baseline. The fever spikes are similar to that of malarial fever with a hot face and a cold face and chills, rigors, and excessive sweating. The chill phase is the phase where there is usually release of the septic emboli into the bloodstream, and that's a time which is ideal for collection of blood sample for culture sensitivity. Patients who are having right-sided sigmoid sinus thrombosis or those who are having extensive thrombosis extending into the superior sagittal sinus can have raised intracranial pressure, which is usually evident as severe throbbing pulsatile headache. One of the classical features of lateral sinus thrombosis is the Grisinger sign, which is evident as painful edema and discoloration over the mastoid emissary vein. This is because of the thrombophlebitis spreading into the mastoid emissary vein. Anemia is a common feature in lateral sinus thrombosis. This could be because of sequestration of RBCs within the clot or because of the hemolysis of the RBCs by the action of the beta hemolytic streptococci. Papilledema on fundus examination also corresponds to the raised intracranial pressure. Tobey-Ayers test and Krobek's test are some classical tests for identification of lateral sinus thrombosis, which were very popular in the olden days and are not that popular with the advent of advanced imaging techniques these days, and also because of the false negatives and the false positives associated with these tests. Tove-Ayers test. The principle behind this test is that when we compress the IJV at the level of neck on one side, then there is raised intracranial pressure because of venous congestion, which is reflected as raised CSF pressure during the performance of lumbar puncture. In a patient with lateral sinus thrombosis, on the side of the thrombosed vein, the compression of IJV does not lead to any change in the CSF pressure because of discontinuity in the flow of blood, whereas the compression of the other side normal IJV instead leads to double time increase in the CSF pressure because that's the only vein through which the entire venous drainage of the brain is happening. In the same way, the compression of the normal side IJV can also lead to prominent retinal veins being visible on ophthalmoscopic examination, which is called as Krobek's test. If a patient with lateral sinus thrombosis develops bilateral proptosis, chemosis, conjunctival chemosis, along with ophthalmoplegia with progressive blindness, this suggests progression of the thrombus towards the cavernous sinus. If the same patient instead develops a tender cord-like IJV in the neck with palpable tender lymph nodes surrounding it and torticollis, then the thrombus is probably extending downwards towards the IJV. If a patient with lateral sinus thrombosis develops severe raised intracranial tension, then it could be related to the extension of the thrombus into superior sagittal sinus and otitic hydrocephalus. Coming on to the investigative workup in a patient with lateral sinus thrombosis for confirmation of the disease. A ear swab can be sent for culture sensitivity. Similarly, a blood culture can be collected and sent for culture sensitivity to identify the causative organism and to identify its antibiotic susceptibility pattern so as to administer culture appropriate IV antibiotics. Peripheral smear can be sent for identification of malarial parasite in patients in whom malaria is considered as a possible diagnosis. X-ray mastoid or plain HRCT temporal bone may reveal background mastoiditis in the form of clouding of mastoid hair cells and destruction of the intervening septae. In a patient with cholesteatoma, there could be frank cavity within the mastoid with erosion of the sinus plate leading to communication between the mastoid and the cranial cavity. Empty triangle sign or delta sign is the classical finding in case of lateral sinus thrombophlebitis on MRI brain with contrast or CT brain with contrast. Here, the inflamed dura of the sigmoid sinus or the lateral sinus appears hyperintense or hyperdense, and the clot in the center appears as a hollow or hypointense or hypodense structure within the triangle. So this empty triangle sign or delta sign is suggestive of dural venous sinus thrombosis. MRI brain is superior to CT in identification of the lateral sinus thrombosis. Here it can detect the venous flow of blood, the obstruction of the flow, and the subsequent reversal of the flow as well. Digital subtraction venography helps in identification of the extent of the thrombus into the various dural venous sinuses. Coming on to the treatment, patients are prescribed culture appropriate IV antibiotics or empirically started off with third generation cephalosporins, aminoglycosides, and anaerobic coverage using metronidazole, like any other intracranial complication of otitis media. A cortical mastectomy may have to be performed in a patient with background acute coalescent mastocytitis, and a modified radical mastectomy may have to be considered in a patient with underlying cholesteatoma. Once the cortical mastectomy or the modified radical mastectomy has been performed, the sinus plate is completely delineated, thinned out, and removed, and the sigmoid sinus is skeletonized. The abscess, if present between the wall of the sigmoid sinus and the sinus plate, is drained out, and then the sigmoid sinus is aspirated. If there is no free flow of blood, it suggests underlying thrombosis. Once the thrombosis is confirmed, the sigmoid sinus is incised partially to completely evacuate the clot and ensure free flow of blood from both the sides of the incision. Subsequently, the site is tightly packed with Surgicel and gel foam to ensure hemostasis. IJV ligation may have to be considered in patients who are having severe thrombosis progressing towards the right side of the heart, or in patients who are not responding to the regular antibiotic therapy and are having repeated release of septic emboli into the bloodstream. Anticoagulant therapy may have to be considered in patients who are having thrombosis extending into the cavernous sinus. Otherwise, its use is controversial. Going on to the complications. The complications of lateral sinus thrombosis include septicemia, multiple pyemic abscesses in various aspects of the body, meningitis, cerebellar abscess, cavernous sinus thrombosis, superior sagittal sinus thrombosis, and otitic hydrocephalus leading to bilateral optic atrophy and IJV thrombosis. I repeat, the complications of lateral sinus thrombosis are septicemia, meningitis, cerebellar abscess, cavernous sinus thrombosis, superior sagittal sinus thrombosis, IJV thrombosis, otitic hydrocephalus, and or bilateral optic atrophy. Hence, overall, lateral sinus thrombophlebitis is one of the important complications of chronic otitis media that we all need to be aware of so as to identify and promptly treat whenever we encounter. Thank you.